Good morning. I'm Dr. Allison Iwerty, Commissioner at the Chicago Department of Public Health. This is your opportunity to have your COVID questions answered. Today is Tuesday, November 10th. As you can see, we don't have a guest today, but I know a lot of people have questions, so we'll try to get through a good number of questions today. You can put them in the box below directly. You can also use a hashtag on Facebook or Twitter, hashtag AskDrArwity. If we don't get to your question today, we are recording and posting individual answers to questions on Facebook on the days that we are not live. So with that, let's go ahead and take a look at our current data. The bottom line is that the data is not good for COVID. The data is not good in the US, it is not good in Illinois, it is not good in Chicago. Really day after day here, we are breaking records as a country, as a state, and as a city in terms of COVID cases. So let's see what that's looking like. First of all, when you come right to our dashboard at chi.gov/COVID- or as always, chicago.gov/coronavirus, and right up at the top, latest data, you'll see on that landing page that our current positivity rate as a city is now up to 13%. 1 month ago, we were still just at that 5% mark, which is where we want to be. And it's just increased dramatically, and that has been true all over the state. As a reminder, that means 13% of the tests that are being done are coming back positive. We also see in the second line here that our testing continues to go up. We're averaging more than 14,000 tests a day here in Chicago, been more than 1.5 million tests done in Chicago. But we know that this is not all related to increases in testing, because testing is up about 7% over last week. And we can see in comparison down at the bottom here, unfortunately, our daily case average is up to 1,686 tests per day. Diagnosed cases per day, and that is up 39% from the prior week. And it's up almost 400% from a month ago. A month ago, we were talking about 5% positivity and being worried about 400 cases per day. 1 month later, we're talking about 1,700 cases every day. We've had days with more than 2,200 cases on a single day. We, as you know, record them on the day that the test is done, but we sometimes get boluses of cases in. And over the weekend, we had a day where we had more than 3,000 cases reported to us. We cannot keep up with that volume of cases, period. When it comes to trying to do the case investigation and the contact tracing, when it comes to needing to think about all the mitigation that needs to happen to keep our spaces safe. This is an outbreak that is in poor control in every part of the city. And let's take a quick look at that demographics data to draw a finer point on that. So we've had about 119,000 people diagnosed with COVID right now. This afternoon at 1 o'clock, I'll be doing a press conference and we'll show some more details of this. But 17% of the people who have had COVID at any point here in Chicago have COVID right now. That's how many people are infectious right now. And we know, remember, that there's about 5 to 7 times as many people who have COVID as who actually get diagnosed and have a test. And that means that there are between 100,000 and 145,000 people with COVID in Chicago right now, meaning infectious, able to spread COVID. And that's why the risk of gathering, unfortunately, is so high, and the highest really that we've seen, certainly in many months. Also, let's look at our deaths here. Do you see this? Our average deaths per day is up to 7 deaths per day. And all summer, we were talking 2 deaths per day, 3 deaths per day, 2 deaths per day, 3 deaths per day. Again, just over this last month, we've seen more than a doubling of our death rate, and that is also going up. If we look quickly at race ethnicity, I'm just gonna, if you click here, and I encourage you to explore this yourself, let's pull it in just over the last, let's say, kind of September, October time. Right on top here, each of these colors, and I'll blow it up, is a different race ethnicity. You can see that increase has been across all race ethnicity groups. We still continue to see Latinx Chicagoans disproportionately impacted, but this is across all race ethnicity groups. Similarly, if we look at age, same thing, and I'll blow it up. This increase, each of these colors is a different age group. What's interesting is the yellow line on the top, that's our 40 to 49-year-olds who right now are having the most COVID, and that's a rate. So it's corrected for how many 40 to 49-year-olds there are. And then really just right behind them in light blue are our 30 to 39-year-olds, and then the red are our 18 to 29-year-olds. So for months over the summer, we were talking a lot about just this red line on top was the highest, the 18 to 29-year-olds. But we've seen that shift in the surge so that really everybody under 50 is now having majorly high rates of COVID. And the more concerning thing is that every one of these age groups has seen increases of 3 to 4 times over the last month, including down at the bottom here are people over 70, are people over 80, our kids. The green line is our people over 60. And that is what is turning into increased hospitalizations and unfortunately increased deaths. So I encourage you to explore some of this data yourself. Right on the top, if you're interested in looking at hospital capacity, you can come here to latest data and go to hospital capacity, get a sense and see, how many people are in the hospital right now. We have just, today, right now, we have a total of 776 people with COVID who are in non-ICU beds, another 247 who, another 192 that are in ICU beds, 104 people on ventilators. And if you continue to explore this, you'll see what the increases have looked like. So now really is the time, we can take that down, to be getting serious, even more so about COVID. If people have additional questions about data, certainly put them in, but let's go ahead and get directly into your questions, if I can pull this up. Okay. So Sam Martin on Facebook, does the case count now include probable cases like the Illinois numbers? It does. And let's talk about what that means. That means that includes both. These are still all people who have had a positive COVID test. It includes both people who have had a positive PCR test, the traditional diagnostic test that we've been using for months, as well as people who have a positive antigen test. And an antigen test, just as a reminder, are the tests that are looking for the protein that the virus produces, as opposed to the actual genetic material of the virus. In a setting where we have this much COVID, antigen tests have a very high, what's called positive predictive value, meaning that if the test is positive, the chances are extremely good that that person has COVID. We worry sometimes in settings where COVID rates are very low, that these antigen tests might be more likely to give you false positives. But broadly speaking, here in Chicago in particular and in Illinois, a probable test using an antigen would be considered to be very, very high predictability for having a positive COVID test. And this is how tests are being counted around the country. So yes, this does include both antigen and PCR tests. It does not include antibody tests. Antibody tests, remember, are the blood tests that look to see, have you had COVID in the past? Have you had an immune response? Those are not about, do you have COVID right now and are you sick with it and are you potentially spreading it? That's about, did you have it in the past? So not antibody tests, but we are including both the PCR and the antigen tests. And the tests that the federal government has been pushing out, these BinaxNOW rapid antigen tests, are the newest tests that you don't need to send to a laboratory, that we're able to have faster results on. We're still learning about the best uses for these tests, but those are included within the numbers. Good question. Tiffany Hagstrom from Facebook is asking, would you explain how a mRNA vaccine works differently than a vaccine we are used to taking? All right, good question, Tiffany. Maybe I'm going to back up for people who may not know the background for that question. So I'm sure people saw yesterday the really good news that one of the vaccines here in the US that is in a phase 3 trial, meaning it's in the big trials with tens of thousands of people, where you're looking to see, does this vaccine perform well in the real world? Is it safe? Is it effective? The vaccine made by Pfizer shared that in the interim analysis, meaning the study is not done, you have to wait in these studies for a certain number of people to get COVID. This is at the most basic level how they work. You enroll, in this case, about 40,000 people, and half of the people get the true vaccine and half of the people get a placebo, basically a saltwater injection. The patient doesn't know, the doctor doesn't know, the researchers, nobody knows who's gotten the real vaccine, who's gotten the placebo. And then you follow people forward and you basically see who gets COVID. And then there is a safety panel that unblinds the data, and that's what happened in this interim analysis. For a trial this size of about 40,000 people, you have to wait for 164 people to get COVID. And there's some other analyses where you look at how many people had severe infection. There's some more pieces, but at the most basic level, you got to wait for that many people to get COVID. So one of the very few good pieces of news is when you have a lot of COVID around, like we have right now, it does make the trials go a little bit faster because unfortunately more people get COVID more quickly. So what they did is they unblinded the trial and took a look and saw that when they looked at 94 cases, what they said was the vaccine was more than 90% effective. We don't have the exact numbers, but that means that the huge majority of those cases of COVID were in people who had gotten the placebo, the saltwater version, and not the real vaccine. That's great news because a vaccine that is 90% effective or more will be extremely helpful in terms of stopping the spread of COVID. It means you would not need to vaccinate as many people to start to get to a true herd immunity state. It means that you're not going to have so many issues with people getting the vaccine and then still being able to get COVID. FDA has said they would approve a vaccine that is even 50% effective. We were sort of hoping for something that was at least 70% effective. If the trials finish, and they've still got to finish, we got to get at least the appropriate amount of safety data, all of the follow-up before we can say this for sure. But a vaccine with more than 90% efficacy is a really good piece of news. Now, back to this specific question from Tiffany. This vaccine, the Pfizer vaccine, is based on a technology using mRNA, messenger RNA. And actually, the next vaccine in line, the Moderna one, uses that same technology. And the idea with these vaccines is that if you think about sort of a traditional vaccine, there are all different ways the vaccines are made, but the most traditional way you might give a vaccine is you weaken the virus or you kill the virus, and you actually inject either a killed version of the virus or a very, very weakened version of the virus so that you don't, the idea is it won't make you sick, but your body can see the weakened or killed version of the virus and mount an immune response so that if you see the real version of the virus, your body will know how to fight that, will know how to have an immune response, and you'll be protected against the real version of the virus. That's simplifying a little bit, but it gives you the idea. The idea of this mRNA virus is that instead of injecting COVID itself, instead of injecting the virus, a killed version of it, a weakened version of it, you're actually injecting some genetic material that teaches your cell how to make a protein that is the spike protein on COVID. So you know how you've seen these pictures of COVID that show sort of a round ball and then spikes sticking off it? Remember, corona is crown. It got named this because under the electron microscope, it sort of looks like a crown. So these spikes on the coronavirus have been a major focus for vaccine producers, even for people who are working developing drugs, because our own cells don't have these spikes, right? Like if we can develop something that can recognize a spike and then fight that spike, we can help fight COVID without having as much of a potential problem for anything within our body. So the spike protein has been a focus for a long time. And the idea with this mRNA vaccine, it's kind of like the recipe for the genetic material goes into your muscle, and then it goes into the cell, and it says, hey, human cell, start producing basically these same spike proteins that the virus has. So not the part of the virus that's making anybody sick, but the spikes. And then the body churns out these spike proteins the body learns, here's what this spike protein looks like, and learns to build the immune response so that if you encounter the real COVID vaccine with its spike proteins, it won't make you sick because you've already learned how to have the immunity to that. So it's exciting because we've not used that approach before in any large-scale vaccines. What makes it harder is that the logistics of this are difficult. And most importantly, still at this point, both the Pfizer vaccine and the Moderna vaccine, which again, neither of these are approved yet, they've got to finish the trials, but assuming that the Pfizer one continues to do as well as it's done and the safety profile looks good, given that the Moderna uses that same technology, we would probably expect that one would do quite well as well. Both of those, because they're the mRNA vaccine, have to be transported at minus 80 degrees Celsius. That's minus 114 Fahrenheit. That's not just frozen, that's like dry ice level, really specialized technology. And it makes the distribution of these vaccines more complicated. We've done a lot of work at the Chicago Department of Public Health, at the state, at the federal level to figure out what this will look like. And you thaw it before you put it in the arm, but because of the way the vaccine is made, there's just some additional logistics around that. So that's in a basic way, the way the mRNA vaccine works differently. And there had been a lot of work for a number of years working on this kind of technology, but it had not been brought sort of fully in a vaccine. So I hope that helped answer your question. I know that was a lot, but we've got a number of questions here about vaccines, so I thought I'd hit them. Okay, Carlene McGill from Facebook is saying, please address the falsehood that hospitals get money for COVID patients. Yeah, thank you, Carlene. So this is, I was really disappointed to see false messaging around the idea that doctors are writing that patients have COVID because they'll get $2,000. This is something that was being said, including by the president. It is absolutely not based in reality. When doctors are filling out their paperwork, whether that is work within the hospital, within the clinic, within the, if they're filling out death certificates, what they are writing in terms of diagnoses does not turn into money for them. And hospitals are reporting on COVID patients because that is how you bill based on whatever diagnosis somebody has. So if somebody has a heart attack, you say they have a heart attack and you bill because they have a heart attack. If they have COVID, you bill because you get COVID. But there is absolutely no falsification going on of hospitals, doctors, or anybody in between making up COVID. Period. There just is not. And if people continue to question you about that, I would point you to the fact that we have seen major increases in deaths sort of overall here, with most of that being accounted for by COVID, but some of it being accounted for increases in cardiac deaths and others where we think about the indirect effects. But there is no making up COVID here. I wish there was making up COVID because we wouldn't have so many people here then filling up the hospitals, filling up the ICUs, and dying from COVID. But as a doctor myself, I am just horrified that people are thinking that somehow people are trying to profit off this. Where people are, particularly in hospitals, working so hard and really putting their own safety on the line to care for people who have COVID. Okay, Mauro Rucci on Facebook says, is there any truth the virus is airborne and not transmitted via droplets, thus making masks ineffective? Okay, so first of all, the main way that this virus still is transmitted, based on everything that we know, the main way that it seems to be transmitted is still through droplets. We've clearly learned that it is possible for this vaccine to be airborne, and there are clearly situations where there has been airborne transmission, particularly I think where we're in sort of close indoor settings where people aren't have masks, particularly if they're shouting and singing, etc. So we've learned that there is certainly some airborne component to this. And that's part of why there's been increased attention to things like ventilation, why you've heard us recommending to have your window open if you're in the car, or have your window open even if you're even if you're gathering inside. And we could talk some more about that. But that piece is very, very small in terms of the risk compared to the risk of being within 6 feet of somebody without a mask. And there is nothing about the fact that there's some airborne component that says that this makes masks ineffective. all of the research shows that when people are wearing masks, just the two-layer cotton masks, the risk of transmission there, if everybody's wearing it, goes down by about 85%. And so if you're taking that mask and you're adding on the social distancing and you're adding on the hand washing, none of these things by themselves completely protect you, right? Any interaction that you're having with a living, breathing human being carries some amount of risk. But nothing here has changed for months in terms of the recommendations. And some of the simplest things that you can do, wearing that mask, staying home when you're sick, washing your hands, keeping your distance, being outdoors rather than in where that's possible. Each of those add on to help protect against COVID. So yes, there is some truth that the virus can be transmitted via air, but that does not in any way equate to saying that masks are ineffective. So good question. Dan Lakin from Facebook says, how you're describing the proteins, it sounds a lot like the HIV virus. Is there any correlation or are any of these medications working to prevent and recover from COVID? So that's an interesting question, Dan. So the way our body works at the most basic level is that we have a genetic code. Humans have a DNA code. The COVID virus and actually HIV both have RNA codes, but they're a genetic code. And that code works like at the most basic level. It's ATGC, if you remember back to biology or ACGU related to RNA. That code is all about building proteins. Like that is what that code does. And then proteins work together to become, an organ, to become a virus, to become whatever it might be. But your point about the HIV virus is well taken, because we've learned so much about HIV that we've been able to think about, for example, mutations, right? Like there's been a lot of conversation about mutations. And we know that at least so far, COVID does not mutate anywhere near as much as HIV mutates, or anywhere near as much as how influenza mutates. But we have learned that the ways in which we know to follow mutations because of HIV, we've been applying that same technology for COVID. Certainly, there's been some work to look at HIV medications and think about, and there's studies that are looking to see, do some of them have some impact on COVID, because a lot of them help modulate the immune system. And we know that some of what makes people get really sick from COVID has as much to do with their immune system as it does the original virus. At this point, none of the traditional HIV medications have been shown at this point to be particularly effective in terms of either preventing or treating COVID, but there is a lot of work in that space. And you're right that there's a lot of parallel. I also think there's a lot of parallel actually related to, for HIV, we talk a lot about behaviors, right? And whether this is safe sex, whether this is thinking about protecting myself and those around me, recognizing that things that I do to protect myself also can help protect the community. There are some similarities there, and we've learned a lot from HIV and been able to take that into the fight from COVID. Here's Local Good Chicago on Facebook is saying, Dr. Ezike noted yesterday that people exposed to someone with COVID-19 should quarantine for 14 days, even if they receive a negative test result. Is this correct? Yes, that is correct. Let's highlight what that is about. So if someone has had a true exposure to somebody else who has COVID, they need to quarantine. And that's because it can take up to 14 days for that COVID to take hold in your body and actually show up in a test or make you sick. And that's why it's not enough to get a negative test result. If I just got infected with COVID today, 5 minutes ago, if I tested today, if I tested tomorrow, if I tested the next day, every test I took would be negative. Usually we start to see people have positive tests if they've been exposed and infected. Usually it starts to be positive in the 5 to 9 day range after they test positive, but still at this point, we've seen people who don't turn positive for as long as 14 days after that exposure. So a negative test result, day 1, day 2, day 3, day 5, day 7, day 9, day 14, at this point, doesn't get you out of quarantine. So I know this is one of the things that can be really confusing, but if you have had a true exposure to someone with COVID, particularly if you've had 15 minutes of interaction with them within 6 feet, especially without a mask, yes, you need to quarantine for that 14 days, and a test result does not get you out of quarantine. So really good question. Aline Oku from Facebook says, my wife went to, it's probably Alan Oku from Facebook. My wife went to Wisconsin to serve as a poll watcher on election day. Since returning home, she's been quarantined and is self-isolating within the house. She took a COVID test yesterday. If those results are negative, can she end quarantine? So that's a little bit related to the last question. So I'm presuming you're here in Chicago, and since your wife went to Wisconsin, she went to one of the states, as you know, that is on the travel advisory, and that is because Wisconsin is still having an outbreak much, much worse than Chicagoans. And so absolutely appropriately, when she came home, if there was a reason she had to travel, upon coming to Chicago, she's quarantining, and that is good, and thank you to her for doing that. She needs to quarantine for the full 14 days. So that is off that last question. A negative test result does not get you out of the 14-day quarantine requirement. And election day was October 3, I think. So we are 7 days out from election day now, meaning if she just had that test yesterday, that was 6 days after. She's in that 5 to 9 day range where, I'm glad she waited that long if she was going to get a test to see. But that test, so chances are starting to be better that she wouldn't be positive, but she does need to complete the 14 days of quarantine. So thank you to people who stood up and helped on election day in whatever way that you did that. But particularly if you did travel to a state like Wisconsin, the 14 days quarantine is required. So thanks for that question. Okay, so Eileen, hold on, but they live in, Eileen Boys from Facebook. If someone who tests positive had their test taken in the suburbs near their workplace, but they live in Chicago, will their result count for the suburb where they were tested or as a case in Chicago? They will count as a case in Chicago. There's a lot of work behind the scenes to make sure that we're not double counting people. And so across the whole country, where cases are assigned is where that person lives. And so there's a lot of, when cases come in sort of through the state or even across states, if someone has a residence in Chicago, they get counted in their place of residence. Good question. Okay, Christina Judge on Facebook. Can you then please explain why you don't need to quarantine if exposed more than 2 days before a person who tested positive first experienced symptoms? Okay, good. I like these questions. So the time a person spreads COVID, when someone is infected with COVID, they are infectious starting from 2 days before their symptoms started is when they start. And then they're infectious, remember, for up to 10 days is the number that we use, assuming their symptoms then resolve. And so if you've been exposed to someone, if they had COVID, let's see, how do I best explain this? First, let's talk about when someone is infected. If I've just been infected with COVID, let's say, remember I told you, I just got infected today. I have been feeling fine. I haven't gotten a test yet. I don't have any symptoms. Let's say my symptoms started tomorrow. No matter when I got my test, if my symptoms started tomorrow, we would consider anybody who was exposed to me, meaning without a mask within 15 minutes, for 2 days before symptoms had onset, as having been exposed to COVID. And then the whole time after they've had symptoms. If somebody doesn't have symptoms, we use the date of test. So if somebody gets tested and they have a positive test and they say, you know what, I didn't have symptoms, we use 2 days before the positive test. And so it's different from, so the question of how long I need to quarantine, I need to quarantine for 14 days after I've been exposed to someone with COVID. The 14 days applies if whoever I've been in touch with today, if I wasn't being responsible and wearing my mask and I wasn't in touch, and I don't have symptoms yet, it applies for everybody who's around me today. They would need to quarantine for 14 days. But it's not like if I say I got COVID today, it's not everybody who was around me for 14 days going backwards. Does that make sense? I think we should get some visuals maybe we'll pull up. We have some good visuals online that help explain this because I know it can be confusing. But the bottom line is, if you were exposed to someone with COVID from 2 days before their symptoms started or their negative test through the whole time that they were infectious, you then need to quarantine for 14 days. So I hope that's clear. Put in some more questions if you have them. I think I'll show some visuals the next time too, because it helps to make it clear. Vidal Anciano Jr. on Facebook. Does the onset of symptoms mean that a test is highly likely to give a true positive? Yeah, so if somebody is having symptoms of COVID and they have a positive COVID test, that is a fantastic test. It's almost 100% for sure that they have COVID. And generally, positive test results here are very good. We trust them. Especially, the PCR tests are looking for the actual RNA of the virus. You don't accidentally have the RNA of the virus if you're not infected with COVID. A positive test is very, very predictive. And especially if you have symptoms, there is no reason at all to doubt that test. The more the problem comes from the quote false negatives, they're not usually false negatives. It's just that somebody's being tested too early before their symptoms have started. So it is also true that the onset of symptoms, that's what I was getting at in this last answer, right around the onset of symptoms is when people are most likely to spread COVID. So unfortunately, the 2 days prior to when their symptoms start and then about the 2 days after their symptoms start is when they're actually spreading the most COVID. That's why the masks are so important, because you've got to wear it every day because you might have COVID right now, even though you feel perfectly fine. And that's really different from a lot of other viruses. Most other viruses get more contagious the sicker somebody gets, the more infectious. And so you think about flu, it's like many days after infection, as people are getting sicker, they spread it more. This one, unfortunately, spreads the best right around the time that symptoms are starting. And that's been one of the reasons why it's been so hard to control. And it's one of the reasons why contact tracing has not been as effective a tool as it has been for a lot of other things. And it's why this primary, just consider, I pretend I have COVID all the time. I wear my mask, I socially distance, I'm very careful with anybody who's got underlying conditions because I could have COVID. And in fact, right now in Chicago, chances are unfortunately higher than they've really ever been that I might have COVID right now and not know it. And so people, sometimes there's this idea that I'm getting tested, therefore I don't have to worry about it. No, I consider myself like I might have COVID all the time, and that's what we need folks to do. Sandra Martin on Facebook, what is considered a true exposure? So an exposure is 15 minutes of contact within 6 feet, not contact, but being within 6 feet. It doesn't have to be 15 minutes consecutive. It can be sort of added up, particularly if you're not wearing a mask. Elizabeth Ortiz on Facebook. My employer is forcing me to work, despite my doctor sending them a letter telling them I was instructed to quarantine for 14 days. So that's a big problem. I would ask you to report that employer through 311. You can call 311. You can also go to 311 online here in Chicago and let us know who that employer is. Where we're hearing about employers that have behavior like this, we are working to make sure they understand that if somebody has been instructed to quarantine, it is in everybody's best interest, especially that employer, to make sure they're quarantined. I'm going to add one other piece off this because it made me think of something. Where we've been doing case investigations and talking to people who are working, about half of the time, I don't have the number right in front of me, but about half of the time, people's symptom onset comes before their last day at work. Meaning about half the time, we do have people here who are continuing to go to work with presumably mild symptoms, sort of hoping they don't have COVID. Maybe they haven't had a test yet. Maybe they're waiting on a test result. Maybe they're just thinking it's probably a cold. It turns out to be COVID, and half the time they were at work while they had symptoms. So for employers and for employees, the last thing we want is spread in workplaces. Where someone has symptoms, they need to be supported to stay home. Where someone has had a true exposure and they've been instructed to isolate to quarantine for 14 days, they also need to be supported in that. So do let us know who that employer is. So Sam and Ham on Twitter is saying, can you explain why you feel comfortable with kids in school? You answered this at a presser, but I didn't catch it. So this is a longer answer, and I think maybe we'll talk about it again on Thursday, because I know folks are interested. But the bottom line is what we've seen is that schools have not been sources of COVID spread by and large, as long as strict mitigation is in place. So as long as you have good masking protocols and you're being careful about them, as long as you have good cohorting and you're making sure that if a COVID case is introduced, you're doing the right thing around quarantining those cohorts, as long as you have good hygiene and cleaning and good case investigation and contact tracing. What we've seen is that here in Chicago, we've had lots and lots of schools open, our private, our parochial schools, also around the state, also around the country, including places that have had really significant outbreaks going on. And we've just not seen a lot of spread within schools. We actually have not had, the Illinois Department of Public Health is defining an outbreak now as 5 cases that are associated with a location, where there's thought to be spread at a location. We've not had an outbreak in a school, like using that definition, in Chicago at this point. We certainly have had cases introduced to schools, and we will continue to see more of that, like as I'm sure you're all seeing in your lives. Like in our own workplaces, we are seeing more people coming in with COVID. But just like everywhere, if you're being careful, if you're wearing the mask, doing the social distancing, we really are not seeing a lot of spread in schools. And so as we've learned more about this, younger kids in particular, less likely to spread COVID. There's more we could say, but increasingly, schools are very much being considered an essential in that setting, in the same way that a lot of our essential workplaces were earlier. And so in Europe, for example, where they've gone, they're having some even worse than here in a lot of cases, outbreaks already. They've done full shutdowns again. You can't go more than 5 kilometers from your house in Ireland. They've kept schools open because, again, they've not been shown to be the significant source of community spread that honestly, I think everybody anticipated that they would be. This does behave differently than flu in that regard. And so I think where we think about kids in school and we see numbers like this, it's especially important to make sure that all of the protocols are in place. And we've been having a lot of conversations with schools to make sure that they're doubling down on those, being more careful. And at an individual school level, you absolutely may need to make a decision to close a school, especially for operational reasons. If you have more kids or adults coming in who have been infected outside the school setting and you're needing to, send more cohorts home, for example, or you're really having additional operational burden. Or if you're seeing spread within a school, you may make a decision to close an individual school. But we've just learned a lot about the risk of spread within schools and have learned that it, again, some of the few pieces of good news in all of COVID have been related to youth. And this has continued to be shown in schools. All right, I think we are just about at time. Thank you for all the questions that everybody's been putting in. We will try to get to some of these on the off days and then be back on Thursday. Sybil Madison will be back, so we'll try to just get through a lot of your questions live again at that day. We do have a press conference this afternoon at 1 o'clock, so if you want to see some more details on data, some more about our travel order, do tune in at 1 o'clock today. Also, a couple of pieces of good news. In partnership with the Chicago Cook Workforce Partnership, the city is providing career support and guidance for professionals who are working in the restaurant industry who may have been displaced because of current indoor restaurant closures or otherwise. So if you go to chaiserves.com, recommending this is focused on servers, but really anyone in the restaurant industry, you can learn more about resources and support for those folks. Also, along those lines, if you have the means, please do consider supporting our local restaurants here in Chicago. We have a new Takeout Chicago challenge. Hashtag is Takeout Chicago. And if you grab takeout from 10 local restaurants between now and December 15, you can enter to win really cool experiences at Chicago institutions. We've got behind the scenes tours at our museums. We've got sort of opportunities to really meet people and learn about Chicago, of course, in appropriately socially distanced ways with small numbers. But go to chicago.gov/takeout. And we know that not everybody has the means to do this, but for those of you who do, now is really the time to be thinking about how to support small businesses here in Chicago, restaurants and otherwise, buying local, keeping our local economy going as much as we can. So, I'm looking at it as a little bit of an excuse to order out and really have been enjoying takeout and delivery from a lot of restaurants in my neighborhood. And if you have the means, please do so as well. Check out chicago.gov/takeout for more. We will be back more times this week for sure with additional information about COVID. Thanks for tuning in. Keep putting your questions in. I think on Thursday, we'll also show you some of the visuals that I like that help separate out this quarantine versus isolation, which I know can be confusing for people. And thanks very much. Please do the things that know work and be safe, Chicago. We'll be back on Thursday live.